In this video, we'll take a closer look at the anatomy of the thoracic wall, exploring its layers, key structures, and functional significance. To do so, we will start with a brief introduction, followed by the anatomy of the thoracic or rib cage, and all its osseous components. Then we'll delve into the different intrinsic muscles of the thorax, its cutaneous and muscular coverage layers. Then we will explore its vascularization and innervation, some key clinical notes and applications, and finally a conclusion in order to summarize all the key points. The thoracic wall is made up of an osteocartilaginous framework, the rib cage, and is maintained by joints and intrinsic muscles. Let's start by detailing the anatomy of the rib or thoracic cage. The rib cage has the shape of a cone made up of muscular and skeletal elements, with a superior opening and a larger inferior opening. Externally, the rib cage has three surfaces. Its anterior surface is formed by the sternum and costal cartilages. Its posterior surface is formed by the thoracic vertebrae and the part of the ribs located behind the costal angles. And its lateral convex surfaces are formed by the majority of the ribs. The superior opening is heart-shaped, inclined downward and forward. It is limited by anteriorly, the jugular notch, laterally, the first ribs, and posteriorly, the thoracic vertebra T1. Its diameter is 5 cm sagittally and 10 cm transversally. The inferior opening is wider than the upper opening, with its plane directed downward and forward. It is limited by anteriorly, the infrasternal angle, defined by the xiphoid process, and the 7th costal cartilages. Posteriorly, the 12th thoracic vertebra, and the 12th ribs. And laterally, the lower border of the last costal cartilage. Moving on to the sternum. It is an impair and median bone of the anterior thoracic wall. It is composed of three parts from top to bottom. The manubrium sterni, the body, that is elongated, and the xiphoid process, small in size. These parts are united by the manubriosternal symphysis and the xyphosternal synchondrosis. Its length is between 15 to 20 centimeters, and its width is 5 to 6 centimeters. The sternum has two surfaces, one anterior and the other posterior. On the manubrium, the sternocleidomastoid muscle attaches, and below it, the pectoralis major muscle. The anterior surface presents also the sternal angle or Louis angle, a prominent ridge of the manubriosternal symphysis. And on the body, three transverse sternal lines that give attachment to the pectoralis major muscle, and the xiphoid process, which gives attachment on its anterior surface to the rectus abdominis muscles. The posterior surface gives attachment on the manubrium to the sternothyroid muscles and the sternohyoid muscle. On the body, to the transverse thoracic muscle, and on the xiphoid process, to the diaphragm. The sternum also has three borders, two lateral borders and one superior. Each lateral border presents 7 costal notches that articulate with the costal cartilages. The second notch is located at the union of the manubrium and the body, and the 7th notch at the xyphosternal synchondrosis. The superior border of the sternum has 3 notches, the jugular notch in the middle, and the clavicular notches laterally that articulate with the clavicles. Let's detail now the anatomy of the ribs. The ribs are flat, long, and curved bones that delimit the thorax posteriorly and laterally. They articulate with the spine and each extends forward with a costal cartilage. There are 12 ribs on each side, numbered from 1 to 12. The first group consists of true ribs, from the 1st to the 7th, they are attached to the sternum by their cartilages. The second group consists of false ribs, from the 8th to the 10th, their cartilage unites with the cartilage above them. And the third group that consists of floating ribs, the 11th and 12th ribs end with free cartilage. The ribs can also be classified into two groups. The ribs from 1 to 7 are called sternal because they are attached to the sternum. And the ones from 8 to 12 are called asternal. Let's move to the general characteristics of the typical ribs, that are ribs from 3 to 9. The typical rib is medially concave, tilted downward and forward, with a slight medial twist of its anterior part. Each rib, from back to front, presents a head, a neck, a tubercle, and a body. The head has two articular surfaces. An upper surface that articulates with the lower costal surface of the adjacent vertebra, and a lower surface that articulates with the upper costal surface of the corresponding vertebra with the same number. The neck, a short region that separates the head from the tubercle. The tubercle is located between the neck and the rib body. It has an articular surface that connects with the facet of the transverse process of the corresponding vertebra. The body, after a short posterior and lateral course, bends forward and laterally, forming a prominent costal angle at the back. It has a lateral surface and a medial surface, and two edges, superior and inferior, the latter housing the costal groove, where the intercostal vascular nerve bundle runs. However, the first rib exhibits certain distinct characteristics that set it apart from the other ribs in terms of structure and function. It is shorter and smaller than the other ribs. Its head has only one articular surface for T1. And its neck is thin and rounded. The first rib's body is also particular. It has two surfaces, superior and inferior, and two edges, medial and lateral. The superior surface of first rib has, in its anterior third, the tubercle for the anterior scalene muscle. This separates the groove for the subclavian vein anteriorly and the groove for the subclavian artery posteriorly. The first rib provides insertion for the muscles, posterior superior serratus, middle scalene, anterior serratus, and subclavius. The second rib is twice as long as the first rib. It provides insertion for the muscles, posterior scalene, anterior serratus, and posterior superior serratus. However, the 11th and 12th rib lack a tubercle and each has only one articular surface for the T11 and T12 vertebrae. Moving on to another component of the thoracic skeleton, we now turn our attention to the thoracic vertebrae. There are 12 thoracic vertebrae, characterized by their articulation with the ribs. For the general features of thoracic vertebrae, each one consists of a vertebral body, which is cylindrical, with two costal articular facets on each side. Each facet forms a half-articular surface for articulation with the head of a rib. Two pedicles, located on the posterior side of the vertebral body. Two vertebral laminae, extending from the pedicles. A spinous process, formed by the union of the two laminae. Two transverse processes, arising at the union of the pedicle and the superior articular process. Each has a costal facet. Articular processes, superior and inferior, protruding above and below the base of the transverse processes. And a vertebral foramen, round and narrow. Moving on to another component of the thoracic skeleton, we now turn our attention to the thoracic joints, which play a crucial role in maintaining the stability and flexibility of the rib cage. First, we have the sternocostal joints. These include 7 joints that connect the sternum to the 7 costal cartilages. The first sternocostal joint is a synchondrosis that unites the first costal cartilage to the manubrium. And the sternocostal joints 2 to 7 are synovial joints. The second is against the manubriosternal symphysis, the 7th against the xiphisternal synchondrosis, and the others correspond to the transverse sternal lines. We also have interchondral joints that unite the contiguous borders of the 6th, 7th, and 8th costal cartilages. The costochondral joint is a syndesmosis between the rib and its costal cartilage. And the costovertebral joints, that consist of the costocorporeal joint, formed by 2 joints that unite the head of a rib to 2 consecutive vertebral bodies through the radiate ligament of the costal head and the intra-articular ligament. And the costotransverse joint, that unites the costal tubercle and the transverse process of the vertebra of the same number through the superior costotransverse ligament, the lateral costotransverse ligament, the interosseous costotransverse ligament, and the costolamellar ligament. Turning our attention to the intrinsic muscles, we explore their anatomy while having an essential role in supporting thoracic movements and maintaining respiratory function. They are fully inserted on the rib cage. They include intercostal muscles that encompass the internal intercostal muscles, the external intercostal muscles, and the innermost intercostal muscles, and the internal thoracic muscles. They also include the external thoracic muscles. The innervation of these muscles is provided by the intercostal nerves. Let's start with the external thoracic muscles. These muscles originate from the apex of the transverse processes of the ribs from C7 to T11. They insert onto the first 12 ribs. And they elevate the ribs, making them inspiratory muscles. The intercostal muscles are located in each intercostal space and include, from outside to inside, the external intercostal muscle, the internal intercostal muscle, and the innermost intercostal muscle. The external intercostal muscle extends from the costotransverse joints to the costal cartilages. The internal intercostal muscle extends from the sternum to the rib angles. And the innermost intercostal muscle extends from the costal angles to about 5 cm from the lateral border of the sternum. Through their tonicity, these muscles unite the ribs and protect the interior of the thorax against atmospheric pressure. These are also auxiliary respiratory muscles. The external intercostal muscles are inspiratory muscles, while the internal and innermost intercostal muscles are expiratory muscles. The internal thoracic muscles, also called the transverse thoracic muscles, are paired, flat muscles that radiate. They originate from the posterior surface of the xiphoid process and extend toward the 3rd and 4th ribs, as well as the costal cartilages of ribs 3 to 6. The cutaneous muscular coverage layers are arranged from superficial to deep and include the skin, the subcutaneous tissue, the fascia, and the muscular layers. Let's start with the muscular layers. They are organized into 2 layers. Posteriorly, from superficial to deep, the trapezius and latissimus dorsi form a strong lower anchoring structure. And the rhomboid and serratus anterior muscles create a continuous plane, connected by a well-defined rhomboid serratus fascia. Anteriorly, the coverage layers consist of a single muscular layer, the pectoralis major in the upper region, which inserts only on the costal cartilages and has no direct rib attachment. It is underlaid by the pectoralis minor and the serratus anterior and external oblique muscles laterally. Let's now explore the vascularization and innervation of the thoracic wall, highlighting the complex interplay of blood supply and nerve distribution that supports its function. Starting with the arterial vascularization. The arterial supply of the thoracic wall originates from the thoracic aorta via the posterior intercostal arteries and via the subcostal arteries. The arterial supply is also taken charge by the subclavian artery via the internal thoracic artery and via the supreme intercostal artery. Also the axillary artery via the superior thoracic artery and the lateral thoracic artery. The venous drainage is ensured by the intercostal veins. And the innervation of the thoracic wall is primarily provided by the intercostal nerves. We will now delve into some clinical applications, particularly focusing on the movements of the thoracic cage. The thoracic cage is elastic and moves with each respiratory cycle between a position of maximal expiration and maximal inspiration. During inspiration, the ribs become more horizontal, leading to an increase in both the anteroposterior and craniocaudal diameters, as well as an opening of the xiphoid angle. This expansion is made possible by the flexibility of the ribs, torsion along their axis, the mobility of the costovertebral joints, the elasticity of the costal cartilages, and, if necessary, an increase in thoracic kyphosis. To summarize, the thoracic wall is an osteocartilaginous and muscular structure articulated with the thoracic spine, whose integrity is essential for proper respiratory mechanics. Its anatomical study is crucial for understanding the pathology of its various components.